We now have one more talk still in the lumen, so to speak, on nutritional requirements for inflammatory bowel disease, and this will be presented by Dale Lee from Seattle Children's Hospital. There you are. Thank you. Yeah, you just need a big one.
Okay. All right. I'd like to thank the organizers for this workshop, for an opportunity for me to come and speak here. I think it's a unique opportunity to think from a variety of different perspectives and learn about how nutrients can be utilized in disease processes. I have no pertinent disclosures, and I'm going to briefly go over a few things here just to give a little lay of the land to begin. We're going to review the biological mechanisms disturbed in inflammatory bowel disease. Second, review the association between diet and the risk of developing IBD. Third, discuss the evidence for unique nutritional requirements for IBD. And finally, discuss the role of nutritional therapy in IBD. So inflammatory bowel disease is a chronic inflammatory condition affecting the gastrointestinal tract. The symptoms include abdominal pain, diarrhea, blood in the stool. There's objective inflammation with this disease condition, and some of the systemic manifestations are fever, rashes on the body, linear growth delay, and poor weight gain. There are two types of inflammatory bowel disease, Crohn's disease being the type which involves any portion of the GI tract from mouth to anus, causing inflammation, and ulcerative colitis involving just disease confined to the colon. So inflammatory bowel disease arises in the setting of a genetic predisposition. There are numerous environmental insults that can occur, and this triggers a cycle of inflammation that continues to perpetuate. There are at least 200 known genes associated with inflammatory bowel disease risk. The known environmental risk factors include antibiotic exposures, certain dietary exposures, and also infections. So when these environmental exposures occur in the setting of a genetic risk, what happens is there can be breach of the epithelial barrier of the GI tract. There can be translocation of microbial products. This stimulates the immune system to react. So the immune system appropriately starts to develop an inflammatory reaction. Unfortunately, in the setting of inflammatory bowel disease, there's not appropriate regulation, and that cycle of inflammation does not turn off. Chronic inflammation can lead to complications including scarring in the GI tract, infections in the GI tract, and also increased risk for intestinal cancers. So it is known that diet and nutrients are important for inflammatory bowel disease. First of all, there have been nice epidemiological studies demonstrating that dietary exposures are associated with the incidence of inflammatory bowel disease. Second, there have been immigration studies that implicate the role of environment in diet. If an individual migrates from an area of low incidence of IBD to a country of high incidence of IBD, the first-degree immigrant doesn't take on the new higher risk, but the children of that immigrant do take on that higher risk profile. Third, we know that exclusion diets can be effective for the therapy of inflammatory bowel disease. I'll go into more detail of EEN, or exclusive enteral nutrition, in a few subsequent slides. These three boxed areas do implicate that Western diet is problematic. And again, this is not quite clear-cut what it is, but specific risk factors that have been identified with epidemiological studies are total saturated fat intake, greater consumption of total polyunsaturated fatty acids, omega-6 polyunsaturated fatty acid consumption, as well as greater consumption of meats. Some protective factors have been intake of fiber, fruits, vegetables, and omega-3 polyunsaturated fatty acids. So when I think about this, it may be the case that these are actually protective and risk factors, or it could be the case that individuals at risk for developing inflammatory bowel disease actually have different nutrient requirements. A few specific nutrient deficiencies to talk about, and also their etiologies. So we know that individuals with systemic inflammation and inflammatory bowel disease have anorexia. So they have decreased global intake of macro and micronutrients. We know that individuals with IBD oftentimes have malabsorption, resultant diarrhea. So I think Dr. Duggan talked about fat-soluble vitamin deficiency, zinc deficiency, similar for inflammatory bowel disease. You can have intestinal blood loss with IBD and thus loss of iron. In the setting of chronic systemic inflammation, you can have anemia. You can also have activated 1,25-hydroxy vitamin D deficiencies. These are not necessarily deficiencies in the vitamin, but actually a functional deficiency, as you may have inappropriate utilization of iron stores to synthesize iron, to synthesize red blood cells. With IBD, Crohn's disease in particular, the most common area of inflammation is the ileum, or the distal small bowel, and because of this, you can develop vitamin B12 deficiencies. So there is a role for nutrient supplementation in inflammatory bowel disease, but in general, the current approach to treating IBD is to focus on control of the active inflammation. As an adjunct, there is specific supplementation that occurs, things like vitamin D, iron, B12 injections, zinc, as well as a variety of other B vitamins. So again, specific supplementation is thought of as an adjunct, and with the control of active inflammation, in general, there is improvement in nutrient status. I want to talk briefly, a little bit more in specific about vitamin D and the risk of developing inflammatory bowel disease. The Harvard Nurses Health Study is a prospective cohort study, longitudinal, with approximately 1.5 million person-years of follow-up data. If you were to take the participants in this study, and this study looked at the quartiles of vitamin D levels in the serum, the lowest quartile had a 25-hydroxy vitamin D level of 22.3 nanograms per milliliter, and the highest quartile 32.2. When you compared the risk of developing Crohn's disease in the highest quartile versus the lowest quartile, it appeared that the highest quartile had a lower risk of developing Crohn's disease with a hazard ratio of 0.54. And if you looked at all four quartiles and did a p-value for trend, it was significant, suggesting that higher vitamin D levels were perhaps associated with lower levels of Crohn's disease incidence. When the similar study was done looking and analyzing for ulcerative colitis, there were no significant associations that could be appreciated, suggesting that Crohn's and UC, though both inflammatory bowel diseases, have different pathogenesis. There have been some trials looking at the role of vitamin D supplementation in inflammatory bowel disease. This first study enrolled 94 adults with Crohn's disease in remission, and they were randomized to either vitamin D3, 1,200 international units per day supplementation versus a placebo. You can see over the 12 months here that the vitamin D levels did increase in the active group, whereas for the placebo group, it didn't change. When you looked at the risk of disease relapse comparing these two groups, it was suggestive that there was a decreased risk of relapse in the D3 supplemented group, with a 13% having relapse versus 29%. As you can see, the p-value is again suggestive but not significant. In this trial of children, 63 children with inflammatory bowel disease, there was a 12-month trial, and it looked at vitamin D supplementation at different levels. Arm A had vitamin D2 supplemented at 400 international units per day, and Arm B had vitamin D2 supplemented at either 1,000 or 2,000 international units per day, depending upon the season of the year. The endpoint evaluated here was markers of inflammation in the serum. So the group with the top panel shows that the group with lower supplementation had higher interleukin-6 levels at the end of the 12-month trial. In the bottom panel, you can see again that the group with lower supplementation had higher levels of C-reactive protein as well. Again, looking at objective markers of inflammation here. Iron is another important nutrient in the setting of inflammatory bowel disease, as anemia is a very common presenting symptom. It has been demonstrated that intravenous iron is superior to oral iron for this population. This is a 20-week randomized controlled trial with 91 adults with mildly active inflammatory bowel disease. The black bars are what represent IV iron sucrose supplementation with a dose of 200 milligrams every 1 to 2 weeks, up to a total dose of 1,000 milligrams. The white bars look at oral ferrous sulfate dosed at 200 milligrams twice daily. The outcomes here you see on the x-axis are an increase in hemoglobin greater than 2 over baseline. Second is anemia at the end of treatment, and finally is reaching mean hemoglobin reference values. As you can see here, the IV supplemented group was clearly superior at reaching all of these outcomes, again suggesting IV is superior to oral. Important additional effects of iron in the GI tract. So we know that oral or enteral iron can have an effect on the intestinal microbiome. We also know that enteral iron has an ability to increase intestinal oxidative stress and subsequently inflammation. Again, these are generally from preclinical models, but there's an opportunity for us to study further and potentially extrapolate to clinical models. I want to talk briefly about hepcidin, which decreases absorption of enteral iron and helps to explain why IV iron may be superior to enteral iron in individuals. So you see here on the top left corner, if you have appropriate intracellular, extracellular iron concentration, you have induction of a protein called hepcidin, which is produced by the liver. Hepcidin causes decreased uptake of iron from the GI tract and decreased mobilization of iron from the liver as well as spleen. In the setting of active inflammation, such as inflammatory bowel disease, hepcidin can be induced. Again, this is a setting where you likely have anemia, and unfortunately, you're decreasing the amount of iron being mobilized from the GI tract as well as your storage sources. In addition, inflammation directly inhibits appropriate erythropoiesis. So I'm going to switch gears and talk about the strategies for treating inflammatory bowel disease. The mainstream approach for treating inflammatory bowel disease is suppressing the overactive immune system. So immunosuppressive medications are utilized, such as corticosteroids, immunomodulators, and biological medications here. It's also known and well established that nutritional therapy can have a role for inflammatory bowel disease. Exclusive enteral nutritional therapy is a formula-based approach that I'll talk about momentarily. And we've also learned that specific exclusion diets have a role for inflammatory bowel disease. There are quite a few different exclusion diets out there. There's much more rigorous study needed, but these are quite provocative and stimulating next-level studies that are more randomized and larger in scale. So what is exclusive enteral nutrition? It's a bit of a misnomer because food we eat is enteral nutrition, but exclusive enteral nutritional therapy for IBD involves a defined formula diet where individuals do not eat regular food but consume formula for essentially their entire nutritional needs. The formula can be consumed out of a can by mouth, or it can be delivered via nasogastric tube or gastrostomy tube. Studies have demonstrated that the type of formula is not important. It can be an intact protein formula, it can be protein hydrolysate, the carbohydrate content can be different, the fat contents can be different, but it appears that it has to be some form of a commercial formula. And this is used both to give caloric supplementation and also as actual therapy to control inflammation in Crohn's disease. And studies have demonstrated that it appears that with exclusive enteral nutrition in Crohn's, there's about 80% induction of clinical remission, so it's pretty high. So this is a study demonstrating the efficacy of EEN, or the formula-based approach. In this study, 37 children in Italy were randomized to either exclusive enteral nutrition formula therapy or corticosteroid therapy and followed over 10 weeks. You can see on the left-hand panel that there was fairly equivalent good achievement of clinical remission, greater than 60% for both groups, not statistically different. If you looked at mucosal healing, so these kids underwent a colonoscopy at the end of the 10 weeks of the trial, and there was direct evaluation for healing of the colonic mucosa. It was quite fascinating here. The nutritional therapy group had greater than 70% mucosal healing, whereas the corticosteroid group had only 30% mucosal healing. Again, suggesting that the luminal delivery of nutrition is powerful here and was actually superior to broad immunosuppression with corticosteroids. So, when I was at the University of Pennsylvania, I had a chance to work with Dr. Gary Wu on this study called the PLEASE study. And this was a study looking at children with active Crohn's disease, and it was an 8-week trial. And the outcomes we looked at were pediatric Crohn's disease activity index, so clinical disease activity, and also fecal calprotectin, which is a surrogate marker of intestinal inflammation that can be measured in the stool. The 3 arms to this study were partial enteral nutrition, so one group consumed about 50% of their daily calories by formula, the exclusive enteral nutrition, and this group consumed the majority of their daily calories by formula. And then the third group was a drug group. So this group was receiving IV anti-TNF-alpha based therapy, so biological medications. When we looked at the consumption of calories for these groups, I'm comparing the partial enteral nutritional and the exclusive enteral nutrition here. We did a calculation of expected estimated energy requirement, and we calculated what percentage of the estimated energy requirement each individual consumed. You can see for both groups they consumed more than 100%, so they were hungry kids. In the partial enteral nutritional therapy group, you can see that about 77% of the calories for their estimated energy requirement were from formula, whereas for the EEN group, 115%. You can see that about 10% of the calories in the EEN group were from food products, and when we did analysis, this was predominantly from like fruit juices. When we looked at outcomes here, so we have the PEN group on the bottom left, the EEN group in the middle here, and the blue bar signifies the outcome of fecal calprotectin at the end of the study, less than 250, and then the red bar is remission of clinical disease activity. You can see here that the EEN group was clearly superior for the blue bar, so an objective marker of inflammation. And then it was also superior for the red bar, so clinical disease activity. So what we've learned from this study is that it's likely not just that there's something inherently good about formula, but perhaps the role of actually eating foods may be problematic for these kids. So nutrition being delivered appropriately is important. So what about if you hold somebody completely nothing by mouth and deliver all of their nutrition via the intravenous route? So this has been studied in the distant past, and it was quite clear that if you made individuals with inflammatory bowel disease nothing by mouth and delivered IV nutrition, you could greatly benefit their overall nutritional status. But the problem was there was no benefit to eventual need for surgery for these patients. We've learned that the contents in the lumen of the GI tract are important for intestinal health. Again, I'm just going to mention fiber here, but there's a variety of specific food components. We know that fiber is fermented to short-chain fatty acids, and short-chain fatty acids provide an energy source to intestinal epithelial cells. There's also a role in promoting immune tolerance. So what about food-based dietary therapy for inflammatory bowel disease? We know this formula-based approach clearly works. So there are a few different food-based dietary approaches that have been gaining in traction. The specific carbohydrate diet, I'll talk about in the next slide, the Crohn's disease exclusion diet, semi-vegetarian diets, and a variety of different anti-inflammatory diets. So each of these diets involves the restriction of certain large food groups. The most commonly avoided food groups are bread and gluten, and also just, and I'll put in air quotes, processed foods, because this is a broad, poorly defined category of foods. For these diets, there's quite a bit of variance in dairy intake, sugar intake, as well as animal fat intake. The specific carbohydrate diet was initially proposed as a dietary therapy for celiac disease before we realized that it's just gluten that needs to be avoided. But on the specific carbohydrate diet, there's a restriction of all grains, so corn, oats, wheat. There's a restriction of all refined sugars, and honey can be used as a source of a sweetener. Cow's milk products are avoided, but you can consume fully fermented yogurt that's been fermented for 24 hours. There, again, is the avoidance of processed foods. So there's an extremely broad following in the GI patient community for a variety of different GI illnesses. A lot of people are using this dietary approach, and there's a lot of anecdotal evidence, but there needs to be more rigorous study done. So there are some concerns about a restriction diet like this. You are eliminating whole food groups from the diet, which can be problematic for nutritional adequacy. For kids on this diet, again, they're pulling out a lot of foods that they like, so you can get inadequate caloric intake and weight loss. And then also there's an impact on the emotional well-being of individuals, in particular kids, if you put them on a strict exclusion diet. So there are some studies on the specific carbohydrate diet. I've just kind of broadly highlighted. If you look at study design, I want to highlight this. These are, in general, mostly case series. So there are not large randomized studies done. Dr. David Suskind and I, we were part of this study where the N of 417, full disclosure, this was a patient survey administered via the internet, and a lot of people were interested in using this specific carbohydrate diet, and they responded that there was clinical benefit. The other smaller studies looked at actual clinical disease activity indices as well as laboratory parameters, and it does suggest, these studies do suggest that there is improvement that was experienced. There are two ongoing large multi-center trials, and in my opinion, this is sort of suggesting and support that small trials can lead to significantly better trials to help more definitively answer a question. In the world of pediatrics, there's an N of 1 study on the specific carbohydrate diet and the modified specific carbohydrate diet. So this is going to have individuals enrolled. They're going to be on the specific carbohydrate diet. Then after 8 weeks, they're going to cross over to a modified specific carbohydrate diet. After another 8 weeks, they'll cross back over to the specific carbohydrate diet. And then again, after 8 weeks, cross back over again. So this will help us answer some questions. In the adult arena at the University of Pennsylvania, they've designed a multi-center study looking at the specific carbohydrate diet versus the Mediterranean diet. 194 participants are anticipated to be part of this study, and individuals will be delivered foods that meet the criteria for these diets for a 6 weeks period of time. And again, they'll be looking at objective markers of inflammation, clinical disease activity, and also the microbiome. So some potential complexities here with inflammatory bowel disease and nutrients. So we know that nutritional therapy is differentially accepted for Crohn's and ulcerative colitis. The formula-based approach, or EEN, is only effective for Crohn's disease. Another wrinkle here. So we know that genetic polymorphisms are associated with efficacy of this formula-based approach to the EEN. NOD2 is a gene that is involved with bacterial product recognition, and polymorphisms of this gene have been associated with efficacy of exclusive enteral nutritional therapy. And finally, we know that if you have active inflammation versus quiescent disease, it may be the case that you process vitamin D and iron differently. We know that for vitamin D, you have individuals with active inflammation have decreased PTH activity and decreased 1-alpha hydroxylation of 25-hydroxy vitamin D at the renal level. Some gaps in understanding. We need to better elucidate the role of specific dietary components on IBD pathogenesis. When I talk about components, I think this needs to go beyond the standard macro and micronutrients. We have to think about food additives and also the products of how we cook foods as well too. Second, we need to develop better methodologies, specifically biomarkers, to assess dietary exposures. And third, it will be important for us to understand the interplay between diet, the intestinal microbiome, the metabolome, and this sort of data will help us to better intervene on an individual basis. And I believe that Dr. Gary will be talking a little bit more on this tomorrow. In conclusion, we know that diet is a risk factor for the development of inflammatory bowel disease, and diet can also be used as effective therapy for inflammatory bowel disease. Second, IBD can result in nutrient deficiencies, and the inflamed state is important to consider. Just correcting the nutrient deficiencies is not enough to treat this condition, though. And finally, we need to do further research to better understand how to best utilize diet as effective therapy for inflammatory bowel disease. I'd like to thank Dr. David Suskind as well as Dr. Johanna Lampe for contributing to this presentation. Thank you.